several things have changed in our healthcare landscape. One thing Dr. Gupta pointed out is that the disease burden has, you know, I wouldn't say, as he said earlier, that the older diseases have completely gone away, but a whole range of new diseases have come. Even the health and wellness centers of the government of India, unlike the earlier sub-center PHC focus, which was on MNCH, now have 12 conditions they need to address. In reality, if you go deeper, there are over 150 conditions that are treatable, at least identifiable in primary care. The challenge has been that despite being a pioneer in the community health worker space, we have not fully utilized the potential of this very powerful workforce to convert these important changes in the disease burden, in the regulation, into something that's actually deliverable and delivered on the ground. And to my mind, if I look around the world, countries that have really addressed this issue in a fundamental manner, countries in our neighborhood like Thailand, countries a little bit further away from us like Alaska, for decades now, they have used the power of the community health worker to deploy very advanced disease treatment in collaboration with doctors. There is no proposal here to transfer prescribing capability to community health workers. And the big step that they have taken, which is the missing step that now IHMR is taking, is the process of certifying the individual. Training, actually, many workers already to some degree have, but they are not certified. There are also some legal skills. For example, phlebotomy is not a skill that can be taught, but you cannot start drawing venous blood unless you are certified formally by a government recognized process, because otherwise you are breaking the law. And you are subjecting both yourself and your patient to harm. Now you might say, why is phlebotomy important? Well, the reality is when I go to a family's home in a rural remote location where diagnostic labs are hard to get, where any case the patient is somewhat reluctant because they are busy with 100 other things, they're running a shop, they've got to go to the farm, you tell them, well, why don't you come back to me with a fasting blood sugar? Well, the person is not going to show up for another 6 months, by which time the disease has progressed quite dramatically. Now there are two directions one could have gone. Like the same issues come up with the health and wellness centers. We have 12 conditions. We can imagine 12 specialized workers. One doing mental health, one doing diabetes, one doing maternal child health, one doing, infectious disease. You can already see that in a village of 3,000, 4,000 people, having 12 health workers deployed is just an infeasible idea. The approach that many countries have taken, and the approach that IHMR has taken, is to go in the opposite direction, is to find a way in which an individual worker can be sufficiently trained, equipped with technology, equipped with protocols, partnered with the appropriate digital connections to doctors and diagnostics, that they can actually offer services to patients, for a full range of diseases. And I'm hoping you will get to hear a little bit from